right. Well, it looks like it's right at the noon hour here in Seattle. So why don't we go ahead and get started? People are still joining, but we'll go through some introduction slides. So give them a chance to join before we get started. Just want to welcome you to today's webinar from the Northwest MHTTC on updating substance use disorder care in the age of fentanyl and stimulants. This is the fourth and final in our webinar series for ACT prescribers, and we're really have been delighted with the series. There's been a great turnout. You guys have been a great group. So looking forward to today's discussion as well with our expert presenters, Drs. Jeremy Welliff and Terence Tomenta. The meeting is, you can see on this slide, the meeting is being recorded, and we can offer certificates. So the certificate of attendance and the recording will be available within a week or two, but there are no CEUs for the series. I'm going to go on and just kind of tell you a little bit about the MHTTC network. I think you guys are all familiar with our network. We're a national network that's funded by SAMHSA that includes 10 regional training and TA centers and a network coordinating office at Stanford. And we really support resource development and dissemination, training and TA workforce development for the behavioral health workforce. I'm Lydia Chwosiak. I'm one of the co-directors of the Northwest MHTTC. We're circled up there. We serve Region 10, which is Alaska, Idaho, Oregon, and Washington. And just a little bit about our center. Our goals are to accelerate the adoption and implementation of mental health-related evidence-based practices, to heighten awareness, knowledge, and skills of the behavioral health workforce, to foster alliances and address training needs among diverse partners, and then to ensure availability and delivery of free, publicly available training and TA. Our area of focus, each of the 10 regional networks has a specific area of focus, and our center's area of focus is evidence-based practices for serious mental illnesses such as schizophrenia and other disorders of psychosis. But we do provide training on a variety of topics, including integrated care, suicide prevention, DEI, school mental health, peer support, many others. All of our training and TA is free, including self-paced online courses, live webinars like this one today that you can attend. You can also view the recording that'll be posted on our website, and also virtual learning communities. So lots of ways to kind of find out about our network. And I'll just acknowledge my co-director, Christina Clayton, who's not joining us today, but is at most of our events. Couple of I think the next slide is housekeeping. So as I said, we'll post the recording of the webinar and slides, as well as a certificate of attendance within one to 2 weeks. But for today, during the webinar, we'll try to use the chat for technical. Peyton from our team will be monitoring the chat. So if you have any trouble with or just sort of general comments or technical issues, put them in the chat. But if you have questions for Drs. Welliff and Tomenta, put them in the Q&A. And I and my colleagues Lorna Moser and Ann Hackman will be helping to monitor the Q&A, so the presenters can either answer them in real time, or we'll certainly save some time at the end, 15 or 20 minutes at the end to do Q&A. We get even an opportunity to unmute and ask your questions. As I mentioned at the outset, we are required by SAMHSA to do a brief evaluation. We're grateful for SAMHSA's support of our funding of our center, and the funding allows us to provide training that's free. So we will be putting a link in the chat for the evaluation at the end. So I think so we'll just shift now to introducing ourselves. Our presenters will introduce themselves, but I want to acknowledge some colleagues who are on the call on the webinar with us today. Dr. Lorna Moser from the University of North Carolina, and Dr. Ann Hackman from University of Maryland. And maybe we'll take a moment for them to introduce themselves. And we'll also, Peyton, why don't you go ahead and launch? We're also curious who's with us today. And so wanted to just have you let us know what your role is on the ACT team so our presenters have a sense of who they're talking with. But why don't I turn over to you, Lorna, just to introduce yourself?
Moser, and I'm the director of the Institute for Best Practices here at UNC Chapel Hill, and I'm in the Department of Psychiatry. And Maria Monroe DeVita and I often are getting together with many of you through these bi-monthly virtual ACT consultations as well. So you may have come across me there. So happy to have you all here with us.
Great. And Anne, you want to say hello?
Sure. I'm Ann Hackman. I'm the Division Director for Community Psychiatry at the University of Maryland in downtown Baltimore. And I am a career-long assertive community treatment psychiatrist. It's great to be here.
Great. It's been wonderful to have you.
Yeah, my name is Bogdan Chodorowski. I'm a PAC psychiatrist with Bridgeway Behavioral Health Services in Northern New Jersey. I'm also a medical director at Bridgeway.
And I think we'll just, thanks for introducing yourself. I think we just wanted to introduce our facilitators who'll help with the Q&A, but feel free to chat who you are and where you're from. And especially if you're in another role, be helpful to know kind of, it looks like most of our folks are in other roles. But why don't I go ahead and without further ado, turn it over to today's presenters. They can introduce themselves and get us started.
Great. Well, thank you so much. Yeah, what a great introduction. I didn't know we would be speaking to so many people today. It is great that you're all here. It's great that you're all interested in this. You look great. Sorry, I'm looking at my screen because the poll keeps popping up on me. I'm just going to close that. But you look great, and we'll get started here. So I am Dr. Jeremy Welliff. I'm assistant professor at the University of Alberta and assistant professor adjunct at the Yale School of Medicine. With me is Dr. Terence Chimenta. Dr. Chimenta, do you want to say hi? If you're there. I think you're there somewhere.
He's on mute right now.
He's on mute.
Oh, I'm sorry about that. Typical rookie mistake. Terence Chimenta. I'm an addiction-trained psychiatrist. I trained at Yale School of Medicine, and I'm starting a new role as an addiction psychiatrist with the Rex Hospital as part of the UNC health system. So
Brilliant.
I'm glad to be here.
Thank you. And a little bit of my background too. I completed addiction psychiatry fellowship at Yale. I then went on to do public psychiatry fellowship at Yale. And I'm often blurring this line between psychiatric settings and substance use disorder settings, which I think is a false dichotomy, I'm sure as many of you know. And so we've designed this lecture to tackle some of those myths and update ACT teams and talk about some of the interesting intersections between substance use disorders and the patients that you folks are all caring for daily. So we're going to talk about some of the work we did, some of the reviews we're working on currently in this space, talk about harm reduction. We really talk about the treatment of opioid use disorder in the age of fentanyl and stimulant use disorder, which I'm sure you folks have all been seeing, especially if you're in the Northwest. The other name of this talk, because that's quite long, is ACT on Addiction. And you should be prepared, and all of your teams should be ready to act on addiction within your ACT teams. Because we know that severe mental illness or psychiatric illness in general and substance use disorders go hand in hand. They are so greatly intertwined that I think at times it's silly to even talk of them as separate things, unless you're talking about specific management of certain conditions. And I think we know from national data and from probably just our own practical experiences doing ACT work that the problems that our patients with both, say, schizophrenia plus a substance use disorder are large. And they're probably some of the sickest patients on your team, or the patients most struggling, and face huge barriers when it comes to getting treatment, being treated well within other healthcare systems that they might be interacting with, being treated well within the carceral system and the legal system, et cetera. So this is super important and very important for our people we see on ACT. We know that substances impact the mind and brain. We have substance-induced disorders, and I quip that we might as well also have mood and trauma-induced substance use disorders when you're talking about the phenomenology and what your patients tell you that wrestle with substance use, right? So this is really blurry, what's coming first between a lot of these. I argue, and I want to please imprint on you, and we can talk about this more, that there has been a lot of siloing between mental health care and substance use disorder care. Some of that is the historical funding of these, et cetera. But as specialists in psychiatry, we own these diagnoses. That if there's anyone responsible for taking care of substance use disorders, it's us and our colleagues in addiction medicine. So psychiatry as a whole and our colleagues in addiction medicine, right? They're ours. They fall in the DSM. We should very much be the experts for this. I alluded to this, but co-treatment is imperative, right? Of co-treatment, I mean of serious mental illness and substance use disorders. It's the standard of care. It's a minimum of psychiatric care. We know that the prevalence is very high. We know that these folks with co-occurring disorders have better treatment outcomes when both are treated for the most part, et cetera. We can talk about specifics. And as we're going to talk about with ACT, it is built into ACT Fidelity, right? The other point that I'd like to imprint on you is that there has been a huge amount of attention on suicide, and rightly so. And even though the outcome is the same, even though mortality is the same, addiction-related overdoses, which is the term I'm going to usually use there, intersects with this so greatly and has not received the same amount of attention. I'm sure within your institution, you have standardized screening for suicide and suicide risk assessments and all of this stuff. But I'm going to guess that your substance use disorder and substance use disorder outcomes and recording are not up to that same standard. I'm just going to guess that one. So even though the outcome's the same, even though we're in the middle, or not the middle, we are during an opioid epidemic or a drug poisoning, toxic drug crisis where many of our patients are dying, they're treated very differently by us. And I think we have a duty to right that and to correct that, or maybe redirect our attention. You have all probably seen this and feel this, but there is a contemporary modern swing back towards institutionalization across the country. It's talk about USA, but also in Canada, where I am, where we have these big calls for forced hospitalization of those with mental illness. So, of course, we had these big calls by the New York mayor in 2022 that we have a moral obligation to kind of sweep these people up and bring them into institutions. And of course, we have a large expansion of the California laws that allow that more easily facilitate involuntary treatment for those with substance use disorders. And so we're in the middle of this. I hope you're probably here already, because this is very topical and everyone is struggling with what to do for these folks. And so I think we see I hope, speaking broadly, we see some of this as history repeating itself, right? In terms of institutionalization or trans-institutionalization, and we should be cognizant of what's going around in the spaces around us. ACT history, you probably don't need this, but as you know, alternative to mental hospital treatment and the history of this, ACT is recovery oriented. I would argue here, maybe impart onto you that there's no real difference between SUD recovery and mental health recovery. They're really the same. Maybe conceptually, maybe the people interested in talking about them are from one field or another, but they're the same. We're really talking about the fullest fulfillment of human life and experience and how we can be facilitators for that when it comes to psychosocial functioning and all of those factors. So it's no difference between SUD and mental health. And within ACT, we're responsible for the full care of the patient. And this is built in to ACT fidelity metrics. And these fidelity metrics exist to prevent generational and program drift, to keep it as true to some of these initial models and well-studied models. And inside of them, which I hope you know, but if you did not know, there are built in are structural components to have SUD specialists on the team and measure outcomes related to substance use disorders. And that these fidelity metrics are aligned with many general principles of addiction treatment, and really harm reduction or tertiary prevention, which I'm talking about, is really the standard of care and part of this recovery orientation. And so when you look at TMACs, just as a refresher, or maybe this is new for some folks, you have a standard to have a SUD specialist on the team who has a number of roles, including assessment, tracking, MI, modeling skills, teaching skills, and being the expert for those with substance use disorders that are being seen by the ACT team. You have a role to treat the co-occurring disorders and you have full responsibility. So comprehensive substance use assessments, tracking stages of change and readiness and stages of treatment, using MI, using cognitive behavioral techniques. And then this person is modeling skills, consulting, training up your teams and training up their skills, attending meetings, etc. Right? Sorry, those are the three there. And there's more, right? So full responsibility for co-occurring disorders. And as I mentioned, there's this explicit statement about aligning with really harm reduction, tertiary prevention philosophies, that we are just simply very much as an ACT principle. We're meeting people where they're at. We're aligning with their goals. We are there when they need us. We're trying to prevent bad things from happening every day, etc. And we need to be thoughtful about this, making sure our teams are prepared to be thoughtful. I imagine it sounds like there's a bunch of ACT directors and ACT team folks, leadership here, making sure your teams are prepared, because it's going to make their lives easier. They're going to feel better about their work. They're going to be able to do better for our patients, et cetera. There's so many reasons to do that. So despite these measures, these ACT fidelity measures and metrics, there's been very little research on ACT and substance use disorder issues in the literature. And that's bad in general. It's also bad because in 2013, we kind of think of fentanyl being introduced to the drug supply. And I think people are struggling to take care of folks with opioid use disorder, stimulant use disorder, with the introduction of opioids and fentanyl and those things. So it's so important. I have the fruit here because I call this academic scurvy, right? I think we need to be paying serious academic attention to this. There's lots of practical attention, I think, on the ground, but I think we need to do better about studying SUD outcomes on ACT teams, and talking about implementation of this and getting some of those best practices and getting everybody up to speed on how to treat those. I would wager another guess that you saw the title of this talk and you're here because you're like, oh, I don't know how to treat addiction. I'm expected to, but there are parts of this that are really, really hard, and parts of this I feel very, very uncertain about. And so at the end of this presentation, we've left time for ideas and workshopping your problems and the things you're facing. Because I think between Dr. Tumenta and I think we've done a lot of community mental health center work and addiction work, and I think we'd love to hear your stories, and where you're getting stuck. So I will pass it over to Dr. Tumenta to tell us about some of the work between ACT and substance use disorders that's already been done.
Thank you, Dr. Welev. And so I'll start my presentation by just kind of reviewing co-occurring disorders, and before we go to the work that we're doing, and just to reinforce that this is SAMHSA data, and happy to hear that SAMHSA grants funds the program that we're on today, and just looking at the numbers, in terms of severity of substance use disorders in the last SAMHSA survey, the National Survey on Drug Use and Health, we can see that most of the people 12 and older are still struggling with some form of alcohol use. There's cannabis that's very prevalent now. We can go down. Is it an issue of legislation, legalization versus decriminalization? And that's another debate for another day. And then there's stimulants, cocaine and methamphetamine making a huge run. And as you may know, we're currently in the fourth wave of an opioid overdose epidemic, and that's largely driven by stimulants. So it's not unusual for us to see that almost half of those with cocaine use disorder do have a severe use disorder. And likewise, those with methamphetamine use disorders, and this is severe. And again, when you think about stimulants in general and other psychiatric illnesses, they mostly co-occur together. Folks use one to cope with the illness, or they actually use one, as in order to perform their duties, or in order to go by and stuff like that. So it's quite interesting to kind of see where we stand in terms of these numbers and know what we have. So one of the things that we encourage is that with your ACT teams, you want to look and break down the patient's population by type of substance use, because the patients who present different challenges to you. Again, just looking at substance use severity level in the past year among those 18 and over, we can see that, again, with those that had a serious mental illness, we can see that about almost 20% of them had a severe substance use disorder. So think about it, it's like 2 out of every 10 patients you see with a severe mental illness do have a severe substance use disorder. And like it's 50% of those with a severe mental illness do have a substance use disorder, be it mild, moderate, or severe. So again, it sounds like co-occurring disorder is the norm rather than the exception in our patient populations, and we need to feel comfortable taking care of them. Again, when we start breaking this down into age categories, and looking at those that have any mental illness without a serious mental with or without a serious mental illness versus those that have a severe mental illness, we can see the age group that we're working with. So the 18 to 25 is kind of predominant, followed by the 26. So that age range is what it's predominant here. But I want to draw our attention to those that are kind of like 18, maybe, okay, 18 or older is the darker one, the very first one. But again, the thing is, it starts from 12. We're seeing like nicotine, tobacco use. That's very common in the young folks, 12 and above. And also with cannabis, that's known as the gateway drug for those patients. Again, these are the patients that we see, and this is the age range where they start using substances and then to present to us. And so we've got a long way to go. Again, just breaking it down. So this is just looking at, past year substance use with those that have a major depressive episode. And again, illicit substance use, they put all of them together. And we can see that folks that do have some history of illicit substance use, they are more likely to present with a major depressive episode, as opposed to those that, with those that had an MDE, they are more likely to use substances, as opposed to those that did not have a major depressive episode. So again, going back to Dr. Weller's point, like, is that substance-induced major depressive episode, or is it a major mode-induced substance use disorder? In this case, and again, looking at marijuana, we can see that the pattern continues for cannabis use, for opioid misuse, for binge alcohol use, and also for tobacco products. That when patients do have a major depressive episode, the risk, or they're significantly at odds of using, have higher odds of using substances, regardless of whatever substance it is, as compared to those that do not have a major depressive episode. Again, imperative for us to treat this patient population. Again, just looking at the interactions, like how many people, other populations have a substance use disorder, an acute mental illness, or like substance use disorder with severe mental illness. Again, I just want us to focus maybe on the intersection, adults who had a substance use disorder with an acute mental illness, with or without a severe mental illness. It's about 20 million of the population that was censored, and those is about 7.4 million that have an acute substance use disorder and a severe mental illness. So our work is cut out for us. No matter how we look at it, our work is cut out for us. And just looking at pattern of substance use, patients with any mental illness, it's about 44% of them with any mental illness, about 44% of them, do use an illicit substance in the past year prior to the survey. And then when you think about those with a severe mental illness, more than 50% of them used an illicit substance in the year prior to. And those without a mental illness, just about 20%. So us in psychiatry and those in addiction medicine, this is the core of our work. We have to deal with all these people and take care of them. And again, when we look at the need for treatment, the need of treatment is huge. We break it down by age group, 12 and older. It's like about 20% of a population, they do need some form of treatment. And if we had to look at access to treatment, very few people do have access to treatment, because I know we would say we don't have a dual diagnosis person, on our ACT teams. It's very difficult to hire and retain such people. So it's difficult. But then again, the treatment need is there. And so we need to feel comfortable to step up to be able to take care of these people, because the need is huge and it's ever growing. Right. Just breaking it down by race and ethnicity and stuff like that, just to see, again, close to 20% of the people do need some treatment, but more groups, there's differences in the ethnic groups. Now, we can all look for what accounts for those differences. We can look at cultural factors, that limit people from seeking care or thinking that they do need care. We can look at other barriers, transportation. We can look at every other thing, stigma, and all of those. And these are things that we found working at the Connecticut Mental Health Center. We deal with a predominantly Black and brown population, and they have all these factors. And when they show up, we have to be comfortable in providing culturally informed care, to these people. And I understand that at some point, we just want to see them. We just want them to show up. Like we would tell our patients, we just want to see you. It's not about you stop using your substance. We just want to see you, because then that gives us an opportunity to be able to engage with them and feel comfortable in working with different age groups or different race, people of different racial backgrounds and ethnicities. Again, we're thinking of where people get treatment, right? So again, people are getting substance, about 13 million people are getting substance use disorder treatment. The bulk majority of them is in the outpatient. So OTPs, be it all of these other places. And then, of course, there are other people. There's telehealth now, inpatient treatments, and then there's the MAT clinics, medication assisted treatment, which I really don't like medication assisted, because it's like, so it's medication for addiction treatment for clinics. And again, the juvenile system, the correctional system is trying, but there's also issues there. And so when we think of where the ACT team falls, it's typically in the outpatient, and that's where we feel like we have to be very comfortable in taking care of these patients, because there is a need, and that's where the majority of the treatment is provided for these patients. Again, when we break it down to looking at the numbers and who actually received treatment, ages 12 and above, in this survey, not many people did get treatment. Less than 50% in any age category received some form of treatment. And it's quite interesting to see that children 12 to 17 will actually receive more treatment than young adults, young adults 18 to 25, and then also older adults from 26. which is quite interesting because we think of the issue of consent versus assent in terms of substance use disorder treatment and privacy rules that surround substance use disorder treatment, and see that when they're younger, they're actually more amenable to treatment, they're more receptive to treatment, and then when they grow older. So that's an opportunity to catch them when they're younger and talk to them and be able to put them in treatment. Again, when we look at where they received treatment, the types and locations of mental health treatment that they received, for those 18 and older, mental health treatment predominates, like as it should, prescription medication then follows outpatient telehealth and other settings. And you see, inpatient setting is not as much because, again, I guess that's what the ACTIM does best, keep people away from getting into the hospitals and then treating them in the community, which is kind of great. Right. We're just looking at treatment received in the past year again by breaking them down versus any serious mental illness and age group and all of that. You can see that we're actually doing great in terms of treating the mental illnesses, right? We're doing great in terms of treating mental illnesses, but in terms of treating the substance use, remember the percentages were quite lower than these. So hence the need for us to be able to integrate services and provide dual services to these patients. And this is important, right? So again, receipt of substance use treatment or mental health treatment in the past, looking at patients that received mental health treatment but no substance use treatment, there were 8.2 million of them, about almost 40%. Those that received both substance use and mental health treatment, there were only 4 million of them. And so that's where we need to be able to improve that. Those that receive substance use treatment but no mental health treatment, it's about 4% of the population, well, that's that subset. And then there's about 8 million people that did not get any treatment. So that's a bigger issue that we need to address for everybody to be able to treat not only substance use disorders, but also mental health. But again, the majority of people, 50% do have co-occurring diagnosis, but we're not treating them. We're only treating about 17% of those people. And that's where some of the issues lie. Yeah, I think this kind of reinforces the point, those that receive treatment, and it's the same thing. So maybe we just skip this slide. And this is kind of a rhetorical question. We already know who the ACTIMs serve, right? But I just thought that, just to kind of reemphasize the severe nature of symptoms that our patients have, they may have a lot of trouble simply just taking care of their basic needs. These are the kind of patients that we deal with. Like some people would say the worst of the worst. That's who come to us on our ACTIMs, right? And they may find it difficult protecting themselves, just feeling safe, having adequate housing, and just staying employed. So these are really people that struggle, really, really struggle, and they need our help. They need those visits. But we have to figure out a way of providing comprehensive services to them. Again, most of our people, they spend a lot of time in the hospitals or maybe living on the streets, they experience homelessness. And this is one thing too that Dr. Willeff and I did. We did street psychiatry while at Yale, and we would go out and work with the homeless populations and stuff like that. And because the street homeless, again, then they tend to use substances or alcohol, and most of the time they will tell you, I just need to smoke cocaine because I need to stay awake. I'm scared for my life. Someone may hurt me. Or when people take over the apartment and they have nowhere to sleep, they have to sleep on the floor. They have to use cocaine to stay awake because they don't know what's going to happen. They don't know what's going to happen to them. And also, they're also afraid of the police, afraid of getting in trouble with the law and all of those issues that they may face. So with that, I thought that maybe we should just recall attention like kind of reemphasize the need for integrated treatment of co-occurring disorders, and that as ACTIMs, we already know we are already doing this, but again, just kind of like we should be providing integrated treatment for co-occurring disorders. And because this model, the integrated dual disorder treatment model, is evidence-based, and it does not only improve the quality of life of our patients with co-occurring disorders, it also helps to address both disorders at the same time, and it's addressed by us in the same organization and in the same team. And the patient typically trusts us as their team to provide everything for them. So it's a kind of a one-stop shop, and we do everything for the patient. And this model, it's evidence-based, and there's a citation there for us. Again, it is multidisciplinary, and it combines not the biopsychosocial approach with also a psychoeducational component, which is mostly what we did in Connecticut. Is like we educated the patient about the symptoms, educated patients about cravings, educated them about the risk of overdose, with whatever thing they were using, how to use fentanyl test strips, how to use naloxone, and all those things, and the safer use strategies, and kind of like did a deep dive with them on each single strategy on how to stay safe. And then the goal is just to address the needs of the clients and the family members, and promotes client and family involvement in service delivery, and also helps them with stable housing to provide the necessary conditions for recovery and employment, as we expect for most of our patients. So these are the core components. I think we do know about these core components. Again, just to emphasize, a substance abuse counseling, it's a huge one. It's a huge one, and that has to be an integral part of these, and pharmacological treatment, not only for the mental health, but also for the substance use disorders, family psychoeducation, group treatment, and participation in other alcohol and drug self-help groups as needed. So when we were working, we thought to ourselves, like Dr. Wolof said, there's really not been much publication on what the ACT teams do in terms of substance use disorders. So we decided to look at what publications have been out there, and if there's things that are going on elsewhere that we can kind of copy and work on or refine and see what is it that's so we just want to summarize what is already known about substance use disorder care within ACT teams, discuss what are the best practices, what we can translate into our settings, and improve care for our patients with co-occurring disorders. So again, there's limited data, but we did find some studies that we would like to share with you. And what I did here was just put down the studies in terms of opioid use disorder and alcohol use disorder and the little highlights, and then it's just so that we get an idea, and then we'll move on to, when we talk about discussion, we can go into the details of some of these studies. So this is a study that was kind of a two-pathway study, which was for patients that were coming from the correctional facility. Patients were recruited from Care Continuum, or those that were coming directly from prison. And again, they used like the severity of substance use disorder, to decide which pathway to be able to place the patients. And they were offered integrated substance use disorder treatment in some things like CBT, therapeutic communities, and substance use management, disorder management. Again, they did have some mixed outcomes in their results. 4 of the studies said 50 to 70% of patients, they had some abstinence, and the severity of substance use tended to increase initially and then stabilize, which is kind of expected when people come out of a correctional system. They kind of lost the tolerance, or they want to go back to the way of using substances as a way of coping, because you come out without tools to be able to integrate the society. So they start using more and more to cope. But eventually, as we work with them and teach them coping skills and techniques and give them kind of things to do or treat their substance use disorders, then the substance use should kind of like stabilize and decrease with time. So it's not surprising to find to see that they had this. And then in this study where they did community outreach intervention to link individuals with opioid use disorders to medication, medication-assisted treatment or medication for addiction treatment that I prefer, and 50% of them, they were eligible for treatment. And so it was a huge sample, almost 1,600 people agreed and had a linkage. And about 92% of them that met criteria were linked with a manager, and then they subsequently linked to medication for addiction treatment. And 86% of them, showed up at intake, which is a great number. I don't know where they did this study. I don't know how, but this is great because we all know that the no-show rate in our clinics, in our hospital is quite high. Even on our teams is quite high. But for some reason, they were able. 86% of the people were able to show up at their intake. And again, they even had a treatment entry was even lower among those that experienced homelessness. And again, this is interesting. 72% of those that received one dose of medication were still in treatment 30 days later. So it's kind of great to understand that, that engagement that we offer on our ACT teams and consistency, it helps our patient to be retained in treatment, which has a positive outcome on morbidity and mortality in patients in co-occurring disorders. So in terms of alcohol use disorder, again, ACT teams have demonstrated benefits in alcohol use disorder outcomes, and mostly with to reduce total alcohol consumption and days of drinking. Again, we do know that reduced days of drinking means lesser effect on the liver, and that's kind of has some positive outcomes on these patients. So one of the studies that we found is this interesting study. Had about 94 patients in 40, we put 45 of them in an ACT model, and then others received treatment as usual. And then at follow-up, again, you see the follow-up was quite interesting with the 98 and 88% respectively at 12 months. So that's quite interesting. Like at 12 months, they had almost 100% of everyone that was assigned to either ACT or treatment as usual coming in. And those in ACT had better treatment engagement and were more often seen in their homes or local community than those with treatment as usual, because we do expect that treatment as usual, you have to go to the clinic. Then there's an added layer of transportation, there's motivation, then there's forgetting to go to the clinic. And then a higher percentage of those had like days abstinence, those were on the ACT team, and they had less unplanned healthcare use than those that had treatment as usual, because even if they had something to go to the hospital, they knew they were going to meet with the ACT team and have that discussed and sorted out, rather than just show up in the emergency room. And so this was a great pilot randomized control trial, and that I think we can look at it and see if we can replicate that. And then there was this one that was looking at treatment resistant or resistant to treatment, looking at 40 people that had some dependence on alcohol. And they were admitted involuntarily for treatment. I think the study was done in New Zealand or somewhere. Again, they just had 40 people. They admitted them to the inpatient treatment prospectively and then followed them for 6 months using questionnaires. So they would ask them questions about their alcohol use, about things that were going on in their lives. And when they were discharged, they followed them up for 6 months. And 6 months after discharge, 25% were abstinent and living in the community, and 17.5% had a reduced alcohol use. These numbers are not great, but again, it's something positive. A further 7.5 were abstinent due to just the idea that they were involuntarily committed to the hospital, so they stopped drinking. Again, and this brings to mind the debate about people that use substance disorders, because we always hear, it's voluntary, so we cannot commit them to treatment, And the question is, if someone is drinking to the point where Jeremy was talking about, substance-related overdoses, versus suicide, are they a danger to themselves and to others? If they're drinking to the point where they cannot function in the community, can we make that argument to involuntarily commit them to substance use disorder treatment? And this is a debate around different states, and I think different states have different rules about these. Again, and this one was looking at hospitalization of severely mentally ill patients with and without problematic substance use before and during ACT treatment. And this was an observational study. And it was a naturalistic observational study. It had 42 patients of 12 different ACT teams. And this was done in Norway. You know, the Scandinavian countries, they have a great culture of giving data and tracking patients longitudinally. And they had 84 participants that had problematic substance use upon enrollment into ACT teams. And 2 years after ACT enrollment, you know, participants with and without problematic use, they experienced a reduction in their total inpatient days. So just being enrolled on an ACT team, whether you had a substance use or not, it helped to reduce the substance use within, you know. And even those with problematic substance use, they had fewer involuntary inpatient days because then they just the human contact and working with other people, you know, didn't require an involuntary commitment for them, for those patients. And then this one was looking at the impact of ACT teams, you know, and client characteristics on the criminal justice outcomes in dual diagnosis, the disorder homeless individuals. And we all know that this is a very dicey place. You know, people that experience homelessness and using substances, and they're more likely to engage in some criminal activity and end up incarcerated, and then they get discharged, and then they come back and then continue to experience homelessness, and the cycle continues. So this was a randomized controlled trial comparing standard of treatment, alternative care, and integrated treatment. And half of the sample was arrested, and a quarter was incarcerated during the 2-year follow-up period. So again, we think about recidivism when it comes to people that are experiencing incarceration. But again, the point here is that neither the type nor the amount of mental health treatment received predicted subsequent criminal behavior. So the idea that we're thinking, oh, because the patient has a substance use disorder or the patient has a mental illness, they're more likely to commit crime. That didn't really hold for this group of population. Again, that just points to the difficulty that we have on our ACT teams, that no matter what we do, if they're coming from the carceral system, it's very difficult to engage with them, and they're more likely than not to return to the carceral system at some point. And that's not a failure on our part as ACT teams in what we do, but this does happen. And the last study here was just looking at treatment of alcohol use disorder, you know, looking from a social point of view, just kind of paying attention to alcohol and homelessness. That's quite common. And standard case management was offered, and it improved patients' housing stability, made them reduce the drug use, and also remove some other working barriers. And then with those that were enrolled in ACT, the ACT was able to improve their housing stability and even had better efficacy for patients suffering from dual diagnosis in this group of patients. Again, this just to put a smile on our face that what we do matters, and this can really help the patients, you know, not just from a medical point, also from a social point of view. So your work is being recognized and has an impact on our patients. Thank you.
Brilliant. Thank you, Dr. Chimenta, for that very detailed review, all of these studies. If there's another message there, and what Dr. Chimenta said at the end was the things you do within your ACT teams have an effect on these patients who are also using substances, and a good effect. And you should remember that, because I know it is easy to fall into that hopelessness for some of these patients, or really feeling really stuck with these patients with co-occurring disorders. So at baseline, you should hopefully, and you're probably doing very good work at the start. So I'm going to briefly describe what we did at our community mental health center, and some of the really fun intersections we did with having access to addiction psychiatry and embedding a 0.2 FTE addiction psychiatrist in an ACT team. And I want to really quickly go through that, because I want to leave lots of time for you folks to bring your concerns forward. Of course, we can't just do treatment of opioid use disorder lecture and everybody retain everything, or of stimulant use disorder lecture and everybody retain everything. And so we just want to workshop with you the problems and things you're facing. So I want to make sure we have time with that. So we'll get into it. So this was done at the Community Mental Health Center in Connecticut. We had access to what we call the MAT clinic, which was medications for addiction treatment, which is an outpatient addiction psychiatry-led consult service for all of the teams in the Community Mental Health Center. It was run by pretty much 2 addiction psychiatrists who had 2 half days a week to see these patients, help out, give recommendations to the team, skill up teams, teach teams about this stuff. And then the other side of it is the ACT team that we have there. And so we were interested in this idea of what happens when you make an addiction doc an ACT doc, and what are the things that they see on the team, and see maybe this things that they don't see happening that should be happening for substance use disorder care. And so we started, as any good QI project would with a stakeholder analysis, and we interviewed all the staff, and there was a general sense that, hey, look, we don't know what to do for these patients with co-occurring disorders. Some of them are getting methadone at the local OTP. Some of them, they go in and out of rehab once in a while. We don't know what diagnoses they have. We don't know the percentage of patients with what diagnoses, et cetera. And hey, over the last couple of years, we had a lot of deaths. We had a lot of overdoses or unexpected deaths. And some of our team members are feeling that in a real way and showing it in a real way. And so we need help here. And we have a couple of those patients where we're just really feeling really kind of stuck with and really hopeless about. Like I said, there was no baseline substance use disorder specific data recording practices. So we did not know what people had when it came to substance use disorders, or what treatment they were offered or getting or had in the past. We, as part of policy and procedure, of course, TMACs were done at times, but we didn't really know how well we were doing when it came to some of the SUD-related ones I mentioned at the beginning. And then throughout the project, we have these qualitative results of what it's like to have a SUD specialist nearby. So we were doing okay when it came to TMACs rating. So I showed these at the beginning. We definitely had co-occurring disorder specialists before an addiction psychiatrist came on as point 2. What some of these folks were doing were maybe meeting some of the metrics you would like. They were seeing some of the patients. Definitely patients with substance use disorders they were encouraged to see, but there wasn't a lot of teaching and skilling up, or it wasn't comprehensive care. We were getting close. We were getting close to some of those functions, but we weren't all the way there and needed some help there. This was an estimate for our baseline, but we were saying, okay, maybe about 50% or so. We are really taking that full responsibility for co-occurring disorders. So that was a nice one. And when it came to the integrated treatment and models, we were sort of meeting some of the harm reduction philosophy. We didn't exactly know, definitely no measurement of stages of change or any of that work. So, like I said, we were doing okay from this perspective. These are we had at the time we started, we had 37 clients on the ACT team, about 50 years old, the average age, mostly male, predominantly Black. This is downtown New Haven. We then took a look at the data. We looked at every face sheet for every patient. We looked at all went through their charts and their notes, and 92% with a substance use disorder, with any substance use disorder. And like we've emphasized here, and you probably already know, substance use disorders are the norm rather than the exception on a lot of these teams. Tobacco use disorder was a little bit lower than you would expect for those with schizophrenia or chronic psychoses. It was only 65%. So that may be a recording gap. About a third with alcohol use disorder. Almost half with at least THC use, heavy use, or cannabis use disorder. So that was okay. Very low amount with opioid use disorder, which is fairly common amongst ACT teams nationally, loosely. But at this time, we were taking on, I think, 3 more patients with OUD, so that's not fully representative. But the most surprising fact that we were able to go through is that almost half of our people had a stimulant use disorder that was very clear. Being in the Northeast, what we're talking about is crack and cocaine rather than methamphetamine that we see in the Northwest or up here in Edmonton. And we know that particularly for this region, this is particularly dangerous. So these are deaths involving cocaine amongst opioid disorders death, which has gone way up in the last 9 years or so. It has gone up disproportionately for Black and non-Hispanic white populations, mostly non-Hispanic Black being the predominant one. This is the ripple effects of the 1980s crack epidemic, right? This is the same communities and et cetera that are facing this and are dying because of the toxic drug supply, the intermingling of drugs in the crack and cocaine supply. This is just like some really big numbers to scare you and emphasize this, that these numbers have gone way up for both cocaine, opioid mortality in Black folks, and then way up in methamphetamine and other stimulant opioid mortality in Black folks. And the regional particularity of this, right? So it sounds like there's people from all over, but you want to be thinking about what are your patients really dealing with, et cetera, and be prepared for that. The Connecticut data, this is just some specific. So this was just to emphasize to our teams that, hey, these are our patients. So these are fatal fentanyl overdoses, particularly disproportionately affecting the Black population in town. And this was the overlying fatal cocaine involved overdoses. Again, same pattern. So just to emphasize that, and this is recent data. This is 2019, 2022. So these are our patients. This is real. So these are the exact people that these numbers are referring to, right? And so when you looked at those with stimulant use disorder on the team, this was 16 on our team, mostly male and 70% Black. So that's what I mean by these are our people. We were able to send a lot of these people to our MAT clinic. 44% of those with a stimulant use disorder were referred when we started this, as we started this process. And 100% of those that were seen by the MAT clinic were started on new medications for substance use disorder, referred to start contingency management. These are actionable referrals. These are not referrals for the sake of referrals. These are, hey, on the ACT team, we're stuck. We need help. Let's do something. We acted on all of them, and pretty much all of them engaged in treatment. Fentanyl positivity, you've heard about it in the news. All of these things, I don't need to drag this out. But of the 16 with stimulant use disorder, only about 40% of them had a urine drug screen on file in the last year. Again, mostly cocaine, that's what our folks were dealing with. 50 of those that did include a fentanyl screen were positive. But as a QI gap, many ACT docs or whoever's ordering the urines did not add on the fentanyl testing. So there was a big gap in those that actually got fentanyl testing, which is important, right? You often have to have it as an add-on. It's not on your typical panel, generally, depending on your institution. So important to know. As we review their diagnoses and we clarify their diagnoses on their face sheets and in their charts, we got 22% of our folks with a new substance use diagnosis. So these were examples where we realized someone had a substance use disorder that we should be doing something about, or that it was severe enough we had to do something. There are about 14 instances also where we refined a clunky diagnosis. And what I mean by that is that sometimes people would just have other psychoactive substance use on their chart, but we're able to turn those into real diagnoses, because without a real diagnosis, you don't know what the treatment is. And so you can do this really important refinement within your teams. So I mentioned we were able to send a bunch of these folks to our outpatient consultation service. 7 ends up being about 20% of the whole ACT team, so 1 in 5, we were able to refer. Most folks, these were folks that the team thought would go, couldn't go, but there were many others that the team felt that were just not quite there yet, not at that stage of change, not ready to come in and talk about their substance use with a specialist, etc. And like I said, these are actionable, 100% actionable. We started these people on new treatments every time. Many of these folks, because we had it right there, were changed their pattern of being a little bit engaged with the ACT team to coming to an outpatient appointment every week to see the addiction specialist, right? Like it was this new level of engagement, this brand new opportunity for change. So anywho, that's kind of just very simple things that can be thought about within a team that are important. We had a bunch of additional interventions. I sat in, or addiction specialist sat in on the team meetings twice a week. We use this time for mini teaching episodes on substance use disorder care, immediate curbsides on, geez, what should I do? This patient is like, you know, doing something really bad, make them stop. So you're right there to provide the teaching, provide the education, and give some next steps. We saw a lot of patients as just curbsides in general, and for patients that the addiction specialist could not see, they were there just to give guideline evidence-based treatment recommendations, to kind of manage from a distance, and maybe that member on the ACT team that really had a connection with them could then do it, right? So that's skilling up our teams so that they are effective, so they feel they have that self-efficacy, being able to do something really well. And what we also created was a SUD group for patients. We had an addiction group that was running every week. We could have our SUD specialists come in, talk about what a MAT clinic referral and seeing a specialist looks like. We did naloxone trainings and giving patients naloxone. On that note, how many of you know how many patients on your team need access to naloxone all the time? We did not know. So when you looked at all of the patients on the team with opioid use disorder, a stimulant use disorder, because the cocaine, methamphetamine supply is intertwined with fentanyl and other bad things, or we're using other risky unknown street drugs, about 50% of our team needed regular access to naloxone. So I sort of invented this idea of naloxone coverage, right? You can think of being covered within a team, doing this very simple evidence-based overdose prevention intervention. So it's a very easy metric to do it within a team, right? How many need it? How many are getting it? We had a nice partnership with our pharmacy where we had supplies of naloxone brought to the ACT team. It was on the same floor. It was right there. We could just bring it, grab and go. You just needed a doc to sign off on it, which was easy to do for any ACT doctor to sign off on it. And your team members could grab and go. And then you record who has naloxone and who doesn't. And every single time you check in with them, hey, did you lose it? Did you use it? Did you give it away? Whatever happened to it? And then boom, right there, they get another one. This is easy to do. We met 100% naloxone coverage in that first couple months of doing this. So it's really easy. This is boring stuff about each of our months. But what you should know, so it's really easy, and came our first cycle. So we did this every 3 months. Come of our first cycle, 91% of the patients that got naloxone needed it at the start of a new cycle. They either lost it, gave it away. We had one client who used it on somebody who was overdosing, so probably saved their life. Like these are the stories that come out of doing something like this. But like many of your teams, we did have multiple patient deaths related to overdose, who did have naloxone for our team, by our team. So So it's not a save all. I get this question sometimes. It's not going to fix everything, but the teams are left knowing that they probably did everything that they needed to do. Feel better about that. Let's get through here. So, like I said, easy to do naloxone coverage. Many patients will likely need it again and again frequently. This is a little bit higher than some of the publications you see out of the on some of the sorry, I've been out of America for 2 months. I'm forgetting all my acronyms. Out of some of the SAMHSA overdose prevention stuff. So this is a much higher rate. I don't know if this is going to be specific to ACT teams and ACT clients, but this is a much higher rate of naloxone need and refill rate. But yeah. So I want to instill in you a couple more lessons, and then I want to give lots of time for you folks. So another reason for hope, another reason to act on these addiction issues is because medications for addiction are very good. They're very good. It's hard once you get patients on them. That's the trick, but they're very good. The number needed to treat for buprenorphine is something like 2, right? Naltrexone for alcohol use disorder, its number needed to treat is somewhere between 9 or 12. This is better than the numbers treated than statins. Like we can really act on these. And there are very nice examples of like through the VA and other things to document this. So there's nice examples of annual documentation requirements. I know your teams are excited about more paperwork, but there are ways that you can structurally embed some of this to improve care, improve outcomes. Oh yeah, so this is the effects on mortality, right? He said number needed to treat 1 to 2 for a decrease of 50% on mortality, right? With buprenorphine or methadone. It's very rare we can say anything like that in psychiatry, but the addiction space is when we can. So you should feel empowered to do this and empowered that you will have a good effect. I want to draw again these parallels to suicide, right? So I'm going to assume that most of you are familiar with zero suicide, which is essentially a framework for getting to 0 deaths by suicide through the active and thoughtful standardization of processes around suicide. So you screen, you document, you do risk scoring, you take action, you measure it, you record it, you do all these things, right? It's embedded in an institution. Like most of your institutions probably have something similar. Why would we allow a lower standard for addiction-related overdoses, right? Maybe because we're like liable for suicide deaths for not doing a proper risk assessment, but we're not really reliable for those that die by overdose. So we have these big reasons for maybe why we don't care as much or don't act on it as much. But we should know that this intersection between suicide and overdose is so tightly linked. And the recording of it on the epidemiology side is very blurry. So when someone dies, is it a suicide or is it an overdose death? Is it an overdose death or is it a suicide? Very difficult to tell unless you have very clear evidence. So this is from a VA publication. You saw probably some of that academic detailing processes that already exist. Patients admitted to the ED for opioid overdose, 100 times more likely to die by drug overdose in the next year, 18 times more likely to die by suicide than the general population, right? So intertwined, such high risk. You should not be treating them differently. This is an example of some of the naloxone stuff. I joke that we should be thinking about naloxone as we think about AEDs and automated external defibrillators, right? Why not put a naloxone in those, right? Naloxone training should be with CPR, which I think it is in some places. And then these are just some dashboards for documenting some of the risk reduction or tertiary prevention around overdose. So I'm going to plant the seed in you now that zero suicide, we should really be doing zero overdose. And maybe you'll see a publication by our team on that idea at some point, hopefully. But that's the hope that we're aiming for. I'm going to put a little note here that harm reduction, there's a lot of politicization of harm reduction. I roll my eyes at that. That's how much I have to talk about this. Harm reduction is risk reduction, which is pretty much just treatment, which is and is really tertiary prevention, right? If we want to use proper language. I hear doctors say, I don't believe in harm reduction. I don't believe, which blows my mind. You would never hear a doctor say, I don't believe in tertiary prevention. So I think we I want to just put that as an aside, as forget the politics around harm reduction. I also quip that it was openly embraced by Trump's Surgeon General. I also quip that even the VA can implement syringe programs and safer use programs and has general national support at the VA level. So even they can do it. I think our folks in the community mental health center working with those most marginalized and in the most trouble can embrace it also. These are guideline driven, mostly evidence-based strategies from syringe programs to naloxone. Harm reduction philosophy, many people don't know, but it's been manualized in some forms and incorporated in randomized control trials, and has shown success as a philosophy of approaching. I don't think I need to convince you on this. I think it, as I said, it aligns with ACT philosophy, just meeting people where they're at. And there's lots of other ACT overlaps there. So with that, I hope now you've fully know, if you didn't before, that mental health and substance use disorders so tightly intertwined, cannot separate them. They are part and parcel of what we do and what we do in ACT, I hope. That we need to think systematically and thoughtfully and directly about how we deliver our substance use disorder care within ACT teams to prevent patients from dying, from having better substance use disorder outcomes and mental health outcomes in general. And that a lot of these very simple and meaningful interventions are easy to implement. It was easy. It was just like me with a clipboard. And these are very translatable across ACT, across psychiatry and medicine settings also, right? Knowing the diagnoses of your patients in a systematic way, knowing who needs treatment and what they're getting and what do they need and what do we want for them next, but where are they at? Who has naloxone, who doesn't, right? These are just the basics. And we can't do all the fancy things if we don't have the basics down, right? So I hope that sticks with you if there's one message. So I put this slide here just for ideas and workshopping. I hope that this stirred up some questions for you. I hope that this stirred up conversation for you. You're probably wrestling with things. Please bring your questions. I put a couple on here. I alluded to that the large impact that fentanyl-related overdoses, overdose deaths, and deaths in general has on ACT teams. So we can talk about that, if that's stuff you're wrestling with, and how to do more with your team around that or talk about that. I think ACT teams particularly struggle with stimulant-induced psychosis and psychotic symptoms. If you want to talk about that, that's totally free. If you want to talk about buprenorphine or long-acting injectable buprenorphine, and like, I have this patient, what do I do? We're free to do that. And if you want to just talk about, hey, how can I do better around overdose? We're totally free to talk about that. So I just want to put those out there. And yeah, I want to thank you all so much for this opportunity. There are so many of you here, which is really great, and I wasn't expecting. But I'll leave it there, and I'd love to hear from all of you. So thank you. And I can't see you. I don't know if there's a moderator that can, if there are questions that come in. There is one in the chat I can see, which I'll just go for, which is what about the role of injectable naltrexone? It's great. Yeah, Jeff, if there's any specific questions, we're thinking of it as, second, third line for OUD, better than nothing, but not as good as getting someone on buprenorphine or methadone. It's sometimes hard for people to get on it, given that they may be currently using opioids, fentanyls, et cetera, right? And you can't use an opioid antagonist and precipitate withdrawal, et cetera. So it's sometimes harder to get people on. For alcohol use disorder, it's fantastic if your patients want it. I think that ACT teams, I think the easiest way to talk about this for ACT teams is you think about long-acting injectable naltrexone and buprenorphine, or the brand name Sublocade, is just like your LAIs for antipsychotics. We had a bunch of patients who would come in and they would get their LAI and their LAI for substance use disorder on the same day. So it was really nice to just embed that in the structures that are probably already happening on your ACT teams. I see a raised hand. Do we want to? Oh, yeah, go ahead.
So on the naltrexone, when you're using it for like the alcohol use disorder or opiate or use disorder, have you seen a decrease in impulsivity in other areas?
Dr. Dementia, do you want to take that? I don't.
Yeah, so exactly. Naltrexone, because it can be also used for some of the behavioral addictions, and the idea is that it targets the reward pathway, and so in turn it involves the impulsivity that's associated with that. But I don't think we actually went out to measure that. So, but it's possible that it does, but I haven't really looked up any studies to see if how it affects that impulsivity.
I would say in addiction practice general, it's really quite rare. There is a literature of naltrexone in ASD, or so autism spectrum disorders, and intellectual disability, where sometimes lower doses of naltrexone have been disinhibiting. I can't say that potential risks, because I've seen it done, would outweigh that of using it for a substance use disorder, if that's helpful.
Well, I have one that has a substance use disorder and a TBI. So, when, in hearing this, I'm like, wow, that might be something to, try for him, because he does have both.
Yeah.
So definitely, I mean, I was hoping to help the substance use disorder, which of course does spur a lot of his behavior. Does spur a lot of the behavior. So then, but the extra bonus of maybe helping with some of the impulsivity. And I have one more question if there's time.
Yeah, sure. I would say test dose, right? Don't you're not doing the injection right away. You're not committing.
Oh, yeah, absolutely.
But yeah, you test dose, go for it. Sounds reasonable. I'll give it a go. Yeah.
So the second thing, when you have like clients that, maybe be seeing their PCP for other things, stimulants, Adderall, gabapentin, maybe benzos, and you feel like they're abusing them, do you contact the PCP, or, how do you handle that?
Yeah, I think we have a duty to be good collaborators in general, right? As principals, right? I hesitate. There's a lot of fine lines you want to maintain.
I know. Yeah.
Right? We're home base for these patients, right? So some of it may just be boundary setting with your collaborator, with your consultants, and making sure everyone's on the same page. You also don't want to be, be the stink of the bunch. And you want to maintain trust, being their long-term ACT team.
Yeah.
The prescriber may not only have them a little bit or know them a little bit, but you're really the home, right?
Yeah.
So that's a fine balance, but we have a duty to minimize risk. We have a duty to make sure people are doing well and using prescriptions properly, et cetera, et cetera. So it's a tough balance. I'm sorry, there's no guidelines.
That's okay. I just was,
guidelines in terms
always
of
searching for, because you're right, there's so many variables, and I think it is going to be one of those where each case, there's no hard, fast rule for any of it, but just always good to hear input back on something like that. And just, when you're making a decision, to have all that other feedback can be helpful when you're in the moment.
Yeah. Hey,
it's a great question. We do have a couple of great questions in the Q&A as well, but I appreciate the question about collaborating with other prescribers. But maybe we can go to a couple of the questions that people have put in the Q&A.
Perfect.
Because there's
Okay.
one that I don't know, Deborah, if you feel comfortable unmuting, but the question relates to methamphetamine use and ADHD. So I don't know if that's about ADHD, treating ADHD in the context of methamphetamine. I don't know. There's there are a number of questions that are implicit in
Sure.
that, but maybe just speaking generally around management of ADHD on an ACT team, and how do you think about methamphetamine use disorder or methamphetamine use in that context?
Absolutely. So, there's so many parts of this story. We know kids with ADHD that is untreated, kids with ADHD at baseline, but and then untreated, have higher risk of the development of substance use disorders, right? That's some of the foundation that we're working on. And so should we be treating that and being really thoughtful about that? Yes, absolutely, right? We should be going that way. For methamphetamine use disorder, and many patients will tell you that they got really, hooked on crack, cocaine, methamphetamine because they used it and they feel more functional, right? They're like focused, they do things. Sometimes they're too focused, sometimes they do too many things, but that's part of it. And often, but maybe everybody feels that way, just like with ADHD medications, but that's the foundation. So, when it comes to methamphetamine use disorder treatment, there have been many trials with stimulants and other stimulant-like molecules. So, modafinil, I'm going to use the brand name Vyvanse. These sort of things have been studied and tried. They do get tried. Usually that's when you're asking your addiction specialist in the moment, can we go for it and do that? I see many patients that are prescribed those up here and in my general addiction practice. It didn't make the stimulant use disorder guidelines. So ASAM released the stimulant use disorder guidelines last year, I believe, 2022 or 2023. And so it did not make it in the medications for that. So it's really kind of specialist driven care, off-label care. If that's the most helpful, Deborah, I don't know if there was any other specific one you had there, but often sticky.
I am muted. Yes, it's really sticky because most of them come in saying I was on,
Mhm.
initial high. I come in, I'm all over the place. I'm not bipolar. I just have ADHD and I need you to prescribe me methylphenidate, Adderall, pick one. And they have a 10-year history of meth use, been clean maybe 4 days. So, my as an NP, my overseeing physician is like, hey, if you've got a meth addiction, stimulant addiction, that's contraindicated to do any type of stimulant for ADHD. And are they truly ADHD, or do we need 6 months to get your brain back, rewired again after being on meth? So what I've used is Wellbutrin. I've used Strattera. I've tried to find other alternatives, naltrexone, to help them get to that place where they're off for like 6 months. I have one success story that way, but 1 out of 2,800 maybe. So
Yeah, it's very hard. You're in the thick of it, Deborah. Yeah. So there are a bunch of other medications that made it to the guidelines. Bupropion and long-acting naltrexone is, there's a decent RCT that exists on that if you're looking for more evidence to back some of those decision making. But it is very, very tricky. I don't know if it's not a complete contraindication, it's more of a practice style. The other thing, of course, you're worrying out for and is stimulant-induced psychoses. So that's where it's extra tricky, and you really want specialist care if you can get it, etc. But there have been studies where stimulants have been reintroduced to somebody with a history of stimulant-induced psychosis, and it can be mostly safe also. So there's a lot of considerations.
Yeah, it's a lot of it's there's not a lot of solid evidence to guide treatment is also a challenge. Well, we have a
I
couple of
want
more questions.
I wanted to add to
Oh
that
yeah, go ahead, Terrence.
conversation real quick and just say I'm a fan of using rating scales and rating scales to kind of like measure the symptoms, patient symptom severity over time. And we know that there's not a good checklist for ADHD, especially adult ADHD, but there is one. There's the adult checklist that we can use, you know. And the thing that I always emphasize with when someone shows up and say, I have ADHD, it's how it affects their functioning. So we want to measure, because again, if it doesn't affect your functioning, it means you yeah, we can be fine. You know, you can tolerate some of the other medications or less stronger medications. And and then if it really affects the functioning, that's when you start thinking, okay, I can consider a stimulant. But again, you want to lay ground rules like, okay, if I'm going to prescribe a stimulant, this is how I'm going to prescribe a stimulant, and this is I have to check drug screens at these intervals. And if I find something that's aberrant, then we have to reconsider this. And I'm gonna stop the medication. So having that conversation, being transparent upfront with the patient and stuff. And a good thing too is to just get a cardiology clearance for this patient that has a history of stimulant use. You know, you get a cardiology clearance just to be on the safer side. Then you have more collaborators on your hand. Because at times the cardiologist will tell you we do not recommend, given that there's some structural issues, then you're on the safer side, you know, having rather than confronting the patient.
Great, thank you for that. Well, I think Peyton did put the link for the evaluation in, so please take a look at that. I think we have time for one or two more questions. There was one about so how did you start the contingency management program? How did you facilitate starting that? And I think people might be that as an intervention, and just wondering if you can speak to that.
Biggest challenges with contingency management is getting your leadership on board. If it's not a funding issue, it is also a big challenge. And if it's not, yeah, funding and getting your leadership on board are the biggest problems. We ended up getting all ready for contingency management. And then I'll tell a story of one client because I think it tells it better. To start, we needed a negative urine drug screen. And he came in every single week to see us, probably from September to March or so, every single week, and was still positive for stimulants. And so was never able to start. So we didn't do too much of the implementation side. We were all ready to go. We set it up, the way we worked around it, the funding and other things, is that we just used the ACT infrastructure for vouchers and gift cards and that sort of stuff. We weren't ready, folks weren't ready to do cash. So that's how we did it. We had a process for explaining the program to patients and how to do it and how they win vouchers and pull from the jar and that sort of stuff. And just went with it. If you're interested in examples, you may have heard, people may have heard, so please stop me, but California did a statewide implementation of contingency management. There are other published examples for CM that may have to be adapted for your location. So yeah, that's the gist of that, if that's helpful. It's tricky. It is one of the best treatments, if not one of the only treatments we have for stimulant use disorder. So it is so necessary, but the implementation is sometimes tricky if you don't have the support you need and the buy-in.
Rowan, the trickiness too, from my vantage point, is how the teams get reimbursed for the contacts. Because sometimes it looks like it's beyond the incentive to shape the behavior of use with using these external rewards. There's a parallel incentive to the agency because they're getting guaranteed contacts and billing by setting up. So there's from what I view, there's a lot of ethical quandaries you got to work out on where's the source of the funds? How do you keep it focused on the clinical piece and not become, not that anyone here would do this, become a money-making business? Especially I've seen agencies that they directly yield the benefits of the lab funds because they have on-site labs that actually can do the billing for the labs. So I think all for it, but I think it's one that really needs some ethical guidelines to oversee the practice in a lot of providers.
Yeah, sticky. Yeah, very sticky. Yeah, I'm almost jealous of those people that have full lab and everything on there. But at the same time, we're balancing those, right? Yeah, that's very, very sticky.
Yeah. Well, and I think just with limited options for evidence-based treatments, just wanting to try to make something work, something like contingency management work, and then all the implementation challenges.
Yeah.
Well, I think we're at time. We've got a couple of more questions that we sorry won't get to, but really appreciate everyone joining today. Wonderful presentation and review of the literature and some really complex management. So just want to thank you both for your presentation today and everyone for joining us for the last of our series.